what are we going to do to prevent those sorts of things from happening and get somebody not sitting in another hospital for 3 weeks before they come to the center?
Thank you, Rob. And so thank you all for being so patient. I know that you've been sitting here for a long time. My background actually is in sleep medicine, so I know that this is the time for everyone's late afternoon dip and alertness, right? So before I start, I want everybody to kind of stretch a little bit. Okay? All right. Now, I want everyone to tell me, hands up, when you went to go do that stretch, how many people took a big deep breath in? Right. So what this is a demonstration that the way your body was meant to work was to do airway clearance several times a day. And you do it without even thinking about it. So the dropout of that big extra breath for the airway clearance is a significant loss. But why is this important in the setting of ALS and motor neuron disease? And the reason is because if we look at mortality from this disease, the mortality is a respiratory mortality. And although there are significant issues with just primary hypoxemia or lack of oxygen, as well as pulmonary emboli, which for those of you who are going to be later in the investigator parts of this meeting, you'll hear more about, the biggest issue is that of infectious disease of the chest. And reducing that infectious disease in the chest is the whole game here. So why do we need assistance? Well, we already saw from Dr. Shaw beautiful pictures of chest x-rays, just like the one in front of you, that show small lung fields, elevated diaphragms, and you'll also notice in this picture that the patient is very constipated. This is all big bowel gas and constipation here. And frequently, as the pulmonologist, I refer to myself as the poop police. Because if we don't treat the constipation, you can't effectively breathe and you can't effectively cough. At the same time, the same patient had a CAT scan done, and what you can see is that there's significant clogging of the airways with big balls of mucus, which is what that white is, and that the right diaphragm is more impacted than the left. All of that is consistent with the fact that this patient does not just have inadequate expansion of their lungs, but little pieces of mucus that are unable to move, like little concretions, that come most often from aspiration, which is why they're more on the right than the left, because as something goes from your upper airway and your throat down into your lungs, it tends to go to the right side. Now, if we look at the reason why this happens, it falls into two big categories. We know that some of our patients with motor neuron disease have a significant impact on their bulbar, or what's otherwise known as their throat muscles. These are the muscles that come here in the lower part of the brainstem, and they support things like talking and swallowing. And what you can see is that this is the electrodiagnostic study of the muscles, like a test that you folks would have had if you had an EMG test. You can see that in the act of swallowing, a patient with normal bulbar muscles is very coordinated in their swallow. And as those muscles drop out, you get a lot of discoordination, and you have to have many, many swallows in order to try and handle food. And that inability increases the risk that food and particles will go the wrong way and land in the bottom of the lung. There it goes. In addition, it's important to remember that as we look at the body from top to bottom, looking at all of the muscles that are served by the nerves of the spinal cord, when we are typically taught in medical school that the most important nerves are the ones in the neck, because those are the ones that serve the phrenic nerve that Dr. Letzen was talking about with the diaphragm pacer. What this slide highlights is that if we look at nerves all the way down through the chest wall, those are going to be important for taking a deep breath, for coughing, and truly clearing the airway, so that weakness outside of those areas of the neck are going to be of significance in airway clearance. And this graph you're looking at is a description of what happens when you actually cough. So here you see flow of air on the y-axis, and on the x-axis we're just looking at sound, okay, or time, I'm sorry. Now what you'll see is that at the very end of the cough, you actually hear what we all refer to as a cough, right, the sound part. the action really comes before you get to the sound, right? The effective part of a cough happens back here. And what happens back here is you take that big, big, deep breath in. That requires the muscles of the chest as well as the diaphragm. And then you close the glottis or the throat here, requiring effective activity of those throat muscles. And then you propel the mucus out of your chest. And then you hear the sound. So it's important to remember that the sound that we associate with cough is not actually the business end of the cough. And so what we need to support is the real business end of the cough. Now, when you come for evaluation to the neuromuscular clinic, you all are probably pretty familiar with this. This is a spirometry test where we say take a deep breath in and blow, blow, blow. And that's the most common test that's done in neuromuscular clinics. Frequently, we do it differently than the average pulmonologist's office. We may add a mask there so that folks with bulbar dysfunction can still perform the test. This is actually a picture from our clinic. Notice that the spirometry device is portable. We want to be able to bring it to our patients. As Dr. Litzen talked about, we want to measure both upright and supine, because when you lie down, you lose the forces of gravity helping that diaphragm come down, and now we can truly see how weak that diaphragm is. So you want to be able to make sure that you take the machine to the patient and get them in a couple positions. Now, if we lived outside of the US, and for those of you who live in Europe especially, cough is most frequently assessed, especially in bulbar patients, by measuring how much pressure you can generate at the nose, not by blowing a breath out, but by sucking a breath in, okay? And that is a very, very sensitive test for lung dysfunction. The problem is what we really want to know about is how effective your cough is. So the best way to measure how effective a cough is to actually measure cough, not just breathing in or blowing out. So what we do is to use what's called a peak flow meter. Now, these devices are typically used for people with asthma, and in asthma, the instruction is take a big deep breath in and blow it out as hard as you can. But because we want to know how strong the cough is, we say take a deep breath in and cough as hard as you can. Now, when we make this measurement, we know that a level of 160 or lower is a sign that someone may not be able to handle their ventilation or cough at all. We know that 270 or above, folks are going to do pretty well. And those without neuromuscular disease are going to be above 500. So you can see that the diaphragm has a lot of room to move before you really get in trouble with it. But it is more than just the diaphragm. There are a bunch of other airway issues that are going to be problematic. Things at the chest wall, cognitive issues, issues with parenchymal lung disease, the mouth, the nose, and even body position. So let's try to review some of those. So the first is to talk about the chest wall itself. Now, the reason that I have this first is because we consider this to be the most important early intervention. In fact, we do this intervention before anyone is symptomatic or has abnormal findings. And what you're going to see in front of you first is that big skeleton of the chest wall, okay? So remember that your chest wall is just like an arm, it's just like a leg. It has ligaments and cartilage, it has articulations and joints. And just like we say to all of our patients, from the time of diagnosis, the most important physical therapy that you can do for yourself is to stretch. Full range of motion to prevent stiffness and to prevent pain. And we want the same thing for the chest wall. So what we do is introduce this device that's here in the bottom. This is just a plain old ordinary ambu bag, which is a silicone balloon and a mouthpiece that you put into the mouth and breath stack, putting breath on top of breath on top of breath until the patient feels what you felt when we first started this talk. The shoulders going back, the chest going out. That's the range of motion that your chest needs in order to stay healthy, like your arms and your legs. And we think that it is never too early to start that intervention. If we look at the recommendations from the Canadian Thoracic Society, and that's what you have on the board in front of you, they emphasize that this therapy has been shown to be beneficial in many situations of neuromuscular disease, both in those that have kyphoscoliosis, like you might see in spinal muscular atrophy or Duchenne muscular dystrophy, or even in spinal cord injury, more similar to ALS, where you have greater involvement of muscles rather than the chest wall. And what you'll see is that the blue lines here represent the increase in airflow that can be obtained by doing these exercises at home, basically stating that this therapy is effective in terms of helping to preserve lung function. Now, this is a shout out to my respiratory therapist, Lisa, here, who's shaking her head like, I cannot believe she put my picture in there. But this is here for a really important point, which is that we have to teach the teachers. In order to effectively have our patients do these therapies at home, we as ALS providers need to teach the respiratory therapists that will be in the home. We need to teach the physical therapists and the occupational therapists and the caregivers, the personal assistants that will be in the home. And part of the job that I take on as a pulmonologist is not just training my patient, but training the support staff that's going to make this work for them. So what you're actually seeing here is an example of our respiratory therapist teaching the respiratory therapists who go to the patient's homes. Now, why is this so important that we need multiple layers of education there? And part of this is because we have accepted that there is a certain number of our patients that will have cognitive impairment as part of their disease. It's more difficult for them to learn. It's more difficult for them to understand the decision about why it's important to do things like clear their airway. So we need to give them levels of support, not just what we do in our office, but what's available in the home. What are available as online options to review this. We need to train family members, OTs and PTs, but we also need to make rigid schedules within the home, because without rigid schedules, our patients have a much greater challenge for getting this done. And if you look at the data from Italy from this year, looking at non-invasive ventilation, right? This is an airway clearance, this is non-invasive ventilation. What you'll see is that the patients here in blue, who are in the top lines, that's their mortality. These patients with the blue lines that have the better mortality, they do not have any cognitive involvement with their disease. Those that have challenges in learning, memory, recall, and decision making, their ability to tolerate their non-invasive ventilation goes down, and their life expectancy goes down with it. Now, this has never been looked at in terms of airway clearance, but we think that it is likely that these two things will act similarly because of the fact that they both involve respiratory care, airways, and mouthpieces. Now that we've done the early interventions, let's talk about some of the later interventions that we're going to do and look at some of these other sources for mucus and secretions, like the mouth, the nose, saliva, aspiration, and of course, secretions that just come from the chest wall. Now, the first thing I'm going to do is I'm going to try to do this top to bottom just for organizational purposes. These are all important, and the order is in the order of importance. First of all, we want to keep the nose open. We know that the nose has a harder time for you to breathe as your diaphragm gets weaker because the nose is so small that it's higher resistance to breathe through. But as you breathe through the mouth, you dry secretions, making them more difficult to get out, and the patient is more uncomfortable because of the dryness. We recommend things like the use of just those little breathe right strips over the top of the nose to open it up. Use nose sprays can be very challenging because it's difficult to sniff those nose sprays back into the nose. So we prefer medications that are oral or in a pill form because they're easier to get in. We recommend using saline-based jellies, nothing here that has petroleum in it, because if the petroleum products get into the lung, they can cause pneumonia. So anything that's saline-based to the nose and to the mouth can be very helpful. And then, of course, for anyone who wonders why I have a baby on a slide about ALS, this is what's known as the little sucker. Now, the little sucker is basically a teeny tiny adapter that can go onto a suction device, but you can use it in the nose in order to help clear those secretions out of the nose, and it can be very helpful. Although you don't want to see the face of my nurse the first time I asked her to order a little sucker. She said to me, Dr. Wolfe, if I do a Google search for a little sucker, I'm going to lose my job. But we've gotten that taken care of. Now, the next thing is to talk about oral care and oral hygiene. And I cannot tell you how strongly I feel about the importance of oral care as part of airway clearance. Now, what you're looking at is a study that was done in patients, half of whom were eating normally, the other half had PEG tubes, and they weren't using their mouth to eat at all. And in those patients who were 100% PEG fed, 75% of them had within their mouth bacteria that are known to cause pneumonia. So that keeping the healthy mouth prevents the downstream pneumonia. And there's a lot that goes into this that I can't get into today. But what I would say is that we want to encourage people to do good oral hygiene, which frequently means that you might need to use a toothbrush like this one that has a suction port on the back of it so that you can brush the teeth and get into the gingiva but not aspirate on the toothpaste or the solution that you're using to clean the mouth. Now, I will tell you that the most effective toothbrush that's ever been looked at for this is made with something called chlorhexidine. And if you were in an intensive care unit, we know that chlorhexidine toothpastes significantly reduce the amount of pneumonia that's seen. Unfortunately, chlorhexidine toothpastes are only sold to hospitals to use in intensive care units. So we tried very hard to find chlorhexidine for our patients as outpatients. Now, there is a mouthwash that you can use that is a chlorhexidine mouthwash, and that works really well. The only chlorhexidine toothpaste that's sold on an outpatient basis is actually for dogs, and it comes in chicken flavor and fish flavor. And I just do not see us using chicken-flavored toothpaste, so we will stick with Pyridex, which is the mouthwash form. So the next thing to talk about is airway clearance of saliva. Now, thick, copious secretions from those that can't swallow their saliva are sort of the bane of all of our existence. Now, in the olden days, all they had was surgery. And my father, who's 75 and is a maxillofacial surgeon, remembers going in and ligating those glands to get rid of the saliva, but it's a very, very painful procedure, and no one does it anymore. And instead, the recommendations from the American Academy of Neurology are that we should use anticholinergic medications like the list that you have before you. And those have been very effective, but they do have limitations, and they don't work for all people. If you get too dry, you can be too goopy. If you're too wet, then you can be too drooly and aspirate too much. And so what we do is tell our patients, we are going to give you nebulized therapies or misted medicines that you can inhale, some of which will dry you up, others of which will thin you out, and we ask the patients to use them as needed. And you see a big list of these medicines up here. And I don't want you to try and memorize these today. What I want you to take away from this is the theory that your doctor isn't going to be able to give you a fixed prescription. This is something that involves the ability to be flexible. Now, the new guy around the block is the use of Xray therapy, like you would use for a cancer patient, that can be done at very, very low doses to the parotid glands to turn them off. And that was known to happen as a side effect of radiation for head and neck cancers. But we always thought, well, how could we harness this for the good? Do a low enough dose therapy that we could knock out the saliva but not cause significant complications from it. And just this year, we have our first paper showing that this may be possible. Now, we don't know a lot of centers that are actively doing this, but I do see this on our radar as a salvage therapy for people that haven't been helped by other forms of therapy for their saliva. Also, in dealing with chest wall secretions, in dealing with the chest and the secretions within the chest, we now need to talk about a huge number of options that we have to get those secretions out of the chest. And of course, now I'm left with like 5 minutes because we want to get the questions in for everyone. So what I'm going to try to do is a whirlwind tour of options for airway clearance. So the abdominal thrust is a practice that a caregiver can do for a patient by supporting the belly during inhalation and then pushing it during exhalation in order to get secretions out. And this manual thrust is frequently paired with some sort of inhalatory technique. And in this picture, you're seeing that ambu bag that we used from our initial chest wall exercises. And what you can see is that if you do the ambu bag to breathe in and the abdominal thrust to cough out, you have the highest vital capacities and peak flows. Another option, and this is very common in many countries, is to use your non-invasive ventilator. So you'll see here that this gentleman has his non-invasive ventilator, and this one has the ability to have 2 prescriptions on it. So we'll put his regular NIV settings and then a higher IPAP setting or inspiratory setting just to help him cough when he needs to. And this is the same patient of ours who's using the cough assist. And I'm not going to go through that because Dr. Shaw just went through it, except to say that the cough assist provides both inhale and exhale. And so to that extent, you don't need to use the abdominal thrust with it. But it's not available in every hospital. So only about 60% of US hospitals will actually have one of these devices. That's a very different model than in many areas of the world. And for instance, in this study that was from the UK, the cough assist devices were used as part of an equipment pool where nurses could use them as needed to try and just get them to the patients that needed them as was necessary. In the end, though, and this is probably one of the most important takeaway slides of the entire talk, what we find is that if you compare every one of those techniques, the abdominal thrust, the breath stacking, use of a home NIV device, use of an elevated IPAP pressure, use of a cough assist machine, the truth of the matter is that they can all work. And when patients are looked at to see which is the best, it turns out that for any given patient, you can't predict it. And the only way to find what's going to work best is to try all of them and come up with the thing that's perfect for that patient. So there's a lot of individual tailoring that's part of this. The last thing we're going to talk about are oscillatory therapies. These involve waves that go to the chest. There are certainly 3 on the market now. High-frequency chest wall oscillation therapy, sometimes called vest therapy, chest cuirasses, and percussive ventilation. The advantages of these devices, they are very easy for bulbar patients to use because you don't have to use your throat. They are very easy to learn, both for caregivers and patients. And if you have underlying lung disease like COPD or bronchiectasis, these are very helpful in clearing the airway. The only problem with these devices is that they don't support exhalation, so frequently they'll be need to use with another technique. And this is a picture of one of our patients who's using her therapy vest. And it's important to know that the best data for this is actually in pediatric neuromuscular diseases, but in the setting of adult ALS, we think that there has been a reduction in infection, and there may be a trend toward the FVC, or the vital capacity, stabilizing a little bit more with the use of this device. So the reality is there are no complications and there's good compliance, and it can be very helpful for many of our patients, especially those that are bulbar. This very, very pink room is one of my patients who's using a chest cuirass, and you can see here with her bright pink wall and her bright pink clothes that this is the negative chest device. And what you can see is that as this machine is on her chest, it's delivering all of these little poop, 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 poops of puffs of air directly to the chest wall, like a million mini coughs. And this is something that's started to be used in many centers, but there are no data in ALS using this device. There will be a device here, though, later in the week if people would like to see it. And this is an interpulmonary percussive device. It does something very similar, but it works at the mouth. So you do it with your nebulized therapy to put those vibrations to break up secretions into the chest wall. And the last thing I want to do, because now I really am out of time, we're putting out a little call out here to Mary Massery, who's with us today, to talk about the importance of occupational therapy and physical therapy, along with the concept of positioning. We want to make sure that as someone is in their power chair that they are well positioned. The thought is this: the floor of your pelvis should be directly in line with your mouth. If those things are not directly in line, the physics of how you cough will be completely off and make it very, very difficult for you to effectively clear your airway. Think about not only what position you're in, but in the future we may even talk more about using things like standing chairs to assist in this process. Also important to remember that as you do that, there's the additive use of the abdominal binder. And when you put that little girdle on to support the belly, it helps to improve cough strength and cough flow. And it should be used when you're upright in that chair. The last thing in terms of airway clearance is to think about the position that you're going to be in when you're asleep. We never want anyone to lay flat, because if you lay flat, it's much easier for secretions to get from the throat into the lungs. We know from data from the intensive care unit, not necessarily from neuromuscular disease, although we think the patients are similar enough that it probably applies, that just elevating the head of the bed makes a huge difference in terms of incidence of pneumonia. So we don't want to see people lower than 30 degrees, and we recommend that they stay at about 35 to 45 degrees. And in the picture that you see here, we're talking about a very inexpensive piece of foam pillow that elevates from below the shoulders so that the throat is completely elevated and the esophagus is completely elevated. And you can't just use a standard pillow to achieve this. Also, anyone who has a hospital bed at home, the hospital beds actually have a measurement, and you can actually measure that you're at 35 to 45 degrees. So thank you all for your very whirlwind tour of airway clearance. I want to thank everyone, the Les Turner Foundation and the International Alliance, as well as our institutions.